Hi everybody, Dr. Mike here. In this video I'm going to tell you exactly what the pH scale represents. I've drawn the pH scale up here and you can see it goes from 0 to 14 or from 14 to 0 depending on how you look at it. When we look at pH itself, remember we've spoken about it in a previous video that P stands for the power of and H stands for hydrogen ion concentration. So all we're measuring is the hydrogen ion concentration. Now usually when we measure other ions like the concentration of sodium ions or potassium ions, we use molar as a unit of measurement. But when we look at hydrogen ions, the number is so small in regards to molar that we use pH instead. Now let me show you the conversion and why it's so important that we use pH and for you to understand it. Again, remember that if something has a pH of 7, it's recognized as being neutral. And an example of something with neutral pH is water. Anything with a pH from 7 to 0, we term acidic. Anything with a pH from 7 to 14, we term basic or alkaline. All right, next point is this. Because we want to have a look at what a pH of 7 represents when it comes to molar, this is what we do. A pH of 7 means that the hydrogen ion concentration is 10 to the negative 7 molar. That's the hydrogen ion concentration. All that means is this. If I were to write down 1.0, it means I need to move that decimal point into the negative 7 positions. Now, if that just said 10 to the 7, I move that decimal point 7 positions in the positive, but it doesn't. 10 to the negative 7. So I move it 1, 2, 3, 4, 5, 6, 7. And there's my decimal point, which means there's now going to be a 0, 0, 0, 0, 0, 0 here. Which means that our new concentration written in the form of molar in regards to hydrogen ion is 0.0000001 molar of hydrogen ion. That's what a pH of 7 actually means. That number is so small. That's why we don't write it down like that. We write it as 7. Now, another important point. If I were to write a pH of 8 in the form of molar, it's 10 to the negative 8 molar, which means we move that decimal point 1 extra position, which now means instead of being 0.0000001, there's 6 zeros there, there's going to be 7 zeros because we've moved it 1 more position. So you could write it as 0.1234567, then 1 molar hydrogen ion concentration. Again, if we were to keep doing this, 10 to the negative 9, 10 to the negative 10, what we're going to find is 1, 2, 3, 4, 5, 6, 7. It's going to be 8 now for 10 to the negative 9. 1, 2, 3, 4, 5, 6, 7, 8. 10 for the negative 10. There's going to be 9. 1, 2, 3, 4, 5, 6, 7, 8, 9. What you can see is as we go from 7 up to 14, the concentration of hydrogen ions gets smaller. Look how small that number is. That is a very, very small number in regards to molar hydrogen ion concentration. But it also means as we move down in this direction, the acidic direction, we get more hydrogen ions. And again, as an example, 10 to the negative 6, 10 to the negative 5, 10 to the negative 4. From 7 to 6, there's going to be 1 less or 1 fewer zeros here. So move it back and there's going to be 1, 2, 3, 4, 5. So you can say 0.1, 2, 3, 4, 5. And we can keep going. Right? As you can see, we keep going down. The number gets bigger and bigger and bigger and bigger. And what that means is this. If you go from a pH of 7 to 6, you now have 10 times more hydrogen ions. If you go from an 8 to a 9, you have 10 times fewer hydrogen ions. This is a big shift. So that means when we look at blood pH, and blood pH being 7.35 to 7.45, you may go, wow, that's not very much. But there is a huge difference between 7 and 8, right? And you can see that this shift is actually a lot bigger than you'd actually think. So we have quite a good buffering capacity. However, we can't go outside of this range. So that's what the pH scale represents. Hi everybody, Dr. Mike here. In this video I want to talk about buffers within the body. Buffers resist drastic changes in pH. We know that our blood has a pH of between 7.35 and 7.45. That's worth putting up. pH of 7.35 to 7.45. And if the blood pH goes below 7.35, it's becoming too acidic. If it goes above, it's becoming too alkalinic. That means that the concentration of hydrogen ions, which dictates the pH, is either going to be too much if it goes in this direction, too many hydrogen ions, or not enough hydrogen ions if it goes in this direction. So what happens in the body is if we don't have enough hydrogen ions, we need to make more. If we do have too many hydrogen ions, we need to reduce it. And this is what buffers do. They resist these drastic changes in pH. All right, so for example, I want to talk about a quick buffer, and a buffer that looks like this. H2CO3. What this is called is carbonic acid. And you should know that the definition of an acid is anything that can donate a hydrogen ion. So that means that this carbonic acid can give us a hydrogen ion. Now, if it does give us a hydrogen ion, what are we left with if we take one hydrogen out of this? We're left with one hydrogen, one carbon, and 3 oxygen, which is HCO3. And because we stole a positive from this, it's left with a negative, and this is called bicarbonate ion. Bicarbonate ion. And this is our hydrogen ion. Again, it's the concentration of the hydrogen ion that dictates the pH. So what we've got here is this. A weak acid which donates a small number of hydrogen ions and leaves us with a weak base. Now, the definition of a base is something that can mop up hydrogen ions. It can bind to hydrogen ions, which means if that can bind to that, this is a reversible equation. And so this can also go in this direction. Now, what we have here is a very simplistic buffer system, where if we don't have enough hydrogen ions, the weak acid will split apart and release hydrogen ions. If we've got too many, it will bind to bicarbonate and go in that direction. Now, our body utilizes this reaction, but with the addition of some other parts. For example, carbon dioxide and water. If you bind carbon dioxide and water, have a look. There's one carbon, there's the one carbon. 2 plus 1 oxygen is 3 oxygen, 2 hydrogen, 2 hydrogen. If you bind carbon dioxide with water, you get carbonic acid. So let's write these down just for completion's sake. Carbon dioxide and water. All right. And that can split itself apart to produce these two. So that's reversible as well. What we've now drawn up here is something called the bicarbonate buffering system. And this is one of the most important biological buffers that we have. Now let me talk about it in regards to how it actually works. All right, this end of the equation deals with the lungs. This end of the equation deals with predominantly the kidneys. Now this is important because when we look at imbalances in regards to pH, we can say if something's wrong here, it could be metabolic or kidney caused. If something's wrong here, then it could be respiratory caused. And this is going to be the basis of respiratory versus metabolic acidosis or alkalosis, right? That's for another lecture. But let's think about it like this. Let's just say we do not have enough hydrogen ions in the body. If we don't have enough hydrogen ions, the pH is going up, right? So remember, it's a reverse logarithmic equation. Have a look at my previous video about calculating pH, right? We don't have enough hydrogen ions. How do we create more? Let's have a look. Carbon dioxide. This is a byproduct of respiration. Breathe in oxygen. Our mitochondria utilize that oxygen and it produces ATP, water, and carbon dioxide. And we don't like carbon dioxide, we want to breathe it out. But in order to go from the cells to our lungs to breathe out, it has to go in our bloodstream. So when carbon dioxide hops in our bloodstream, most of our bloodstream's water. Inevitably, all our carbon dioxide is going to be binding to that water, and it will be producing carbonic acid. But because carbonic acid is a weak acid, hates itself, splits itself apart, and produces hydrogen ions, which means one way we can increase the concentration of hydrogen ions in our body is through the accumulation of CO2. How can we accumulate CO2? I'll show you. Hold your breath. If you're holding your breath, you're not breathing out. And this is what happens. Some individuals who do not have a high enough concentration of hydrogen ions in their blood, they may be holding their breath a little bit. Their breathing will be different. Let's think of it flipped. What if we have too many hydrogen ions? Well, if we have too many, the bicarbonate will mop it up and produce carbonic acid, which will then split up and produce water and carbon dioxide. So if we are acidic and our pH is too low because we have too many hydrogen ions, we end up producing more carbon dioxide, which means the patient may breathe more. So the respiration can be an indication of the blood pH. And you can also see if we don't have enough hydrogen ions, it goes in this direction. If we have too many, it goes in this. And this is the bicarbonate buffering system. Hi everyone, a lot of health students have issues with looking at acidosis or alkalosis. This is determining whether the blood is acidic or basic compared to its normal blood pH. Now, there's different types of acidosis and alkalosis. You can have respiratory or you can have metabolic. Now, what I want to talk to you about today is what makes one respiratory-based acidosis alkalosis or metabolic-based acidosis alkalosis. So like I said before, your blood pH needs to sit between the range of 7.35 and 7.45. That's the range that it needs to sit within. If it goes below this particular range, acidosis. If it goes above this particular range, alkalosis. That's the first point. Next point is when we measure pH, the H simply stands for hydrogen ions. That's all we are measuring in this case. But when we do bloods to have a look, when you get medical professionals taking bloods to have a look at whether somebody has acidosis or alkalosis, they don't just look for the pH, they also look for some other factors to tell it whether it's respiratory or metabolic. Let's take a look. All right, first thing is you must know this equation. The equation is that when you breathe, you produce carbon dioxide. This carbon dioxide will inevitably get into your blood, and blood is filled with water. So when carbon dioxide mixes with water, it produces something. The thing it produces is called carbonic acid, which is H2, there's the H2, C from there, O3, because there's 2 there and 1 there. Now, carbonic acid hates itself and splits itself apart, and it produces these two things. It produces bicarbonate ion and it produces hydrogen ions. Again, when we measure pH, we're just measuring this. So if somebody has acidosis, it means that the quantity or concentration of this is going up, right? If they got alkalosis, the concentration of this is going down. Now, think of this on a seesaw. If you increase carbon dioxide, this goes up and everything falls in this direction, producing more acid. So the more carbon dioxide, the more acidic. The more acidic, it means it's going down in this direction and the person has acidosis. Usually the body's very good at compensating and it will bind with that and roll back down in this direction and you'll breathe that carbon dioxide out. All right, let's talk about acidosis, alkalosis, different types. When we look at respiratory-based acidosis, alkalosis, it's looking at this end of the equation. When we look at metabolic, it's looking at this end of the equation. Now, when somebody has respiratory acidosis, what happens is it's respiratory based, something to do with breathing. Carbon dioxide is the only thing here that we truly breathe. We do breathe out a little bit of water, but mainly carbon dioxide, right? So if somebody has respiratory acidosis, the carbon dioxide levels must be increasing. Respiratory acidosis, increased carbon dioxide, because this means it binds with the water, produces carbonic acid, splits apart and produces hydrogen ions. This is acidic. That's respiratory acidosis. So what happens with the pH? It goes down, dropping down in this direction. All right, that's respiratory acidosis. What about respiratory alkalosis? Well, it's going in the opposite direction. So in respiratory alkalosis, we're not producing enough CO2. So it's not binding with water, it's not creating carbonic acid, and we're not producing enough hydrogen ions, which means we've just got an overabundance of bicarbonate, comparatively, and it becomes more acidotic. So it's a drop in CO2, which results in an increase in the pH. This is respiratory acidosis, respiratory alkalosis. What about metabolic? Metabolic acidosis. Metabolic acidosis is referring to what's happening here. Now think about it. Metabolic acidosis can happen either if you increase the amount of hydrogen ions or if you decrease the amount of bicarbonate, because bicarbonate binds the hydrogen to mop it up and get rid of it. So if that's gone, you're just left with a whole bunch of free hydrogen ions. So when you do the bloods to check for this, in metabolic acidosis, what you'll find is a drop in bicarbonate. This again is if it's uncompensated, and an increase and a drop, in the pH because it's acidosis, so it's going down. In metabolic alkalosis, what's happening is it's producing too many bicarbonate ions, or again, it could be the fact there's not enough hydrogen ions. Maybe one or the other. But what we do know is that in alkalosis, there's more bicarbonate ions if it's uncompensated. And what happens is the pH goes up as well. So this is just a very quick run through of what happens in respiratory-based acidosis alkalosis and metabolic-based acidosis alkalosis. So let's have a quick look at how the blood in our body moving through into the kidneys gets filtered and ultimately forms urine. So we're going to have a look at urine formation. So a couple of things, you need to go through the previous videos and understand what a nephron is and understand how the blood supply gets to the nephron and how that blood supply starts to become filtered. Okay, so just as a very quick recap, we're going to go through some functional anatomy and we're going to name different aspects of this nephron. So remember, this is the functional unit of the kidney. This is the filtration unit, is the nephron. And what you can see is a blood supply coming through. Now this blood supply isn't here to give this nephron oxygen. This blood supply is coming in because here is a capillary bed. Now remember, this capillary bed is called the glomerulus. Remember, glomerulus means ball of yarn. So you've got a blood vessel coming in that branches into this glomerulus, capillary bed, and this is where filtration happens. And remember, the tubules here of the nephron contain what's just been filtered from this blood. And so this is called filtrate. And if this filtrate remains in the nephron all the way through, it comes out as urine. Okay? So urine formation has to do with this filtration process here, okay, and what's happening to this filtrate all the way through the nephron. That's what we're going to discuss today. But before we begin, let's label some things so that you know exactly where we are. So, first thing is that we have blood coming into or towards this nephron. Remember, this is called the afferent arteriole. And the afferent arteriole comes down into a capillary bed, which we call the glomerulus. The glomerulus then continues down into not a vein, remember, but an artery, another arteriole, which we call the efferent arteriole. And you can see that the efferent arteriole continues and it basically hugs all the tubules of the nephron, and we call this peritubular capillaries. Okay? Why does this capillary bed here hug the tubules of the nephron? Because remember, what gets filtered into the nephron doesn't necessarily stay in the nephron. 99% of this filtrate that gets into the nephron actually gets thrown back into the blood, and it gets thrown back into this peritubular network. Okay, so that's labeling the blood supply. Let's label the nephron. Now I'm not going to write the labels down because I'll have to rub them out, but what you can see is the first part here we call the glomerular capsule. Okay, so that's the glomerular capsule. Looks like a little Pac-Man. The first portion of the tubule closest to the capsule is called the proximal convoluted tubule. Proximal because it's closest to, convoluted because usually you'll see it as these squiggly wavy lines, but I've just drawn it here straight for simplicity's sake. So proximal convoluted tubule. You've got the loop of Henle, also known as the nephron loop, which is made up of the thin descending loop of Henle and the thick ascending loop of Henle. Then you have the distal convoluted tubule, and then you have the collecting duct. Okay? Now, when it comes to urine formation, what you're going to find is a couple of things. That urine formation is actually equal to a couple of things. Urine formation is equal to glomerular filtration. What that means is, remember, our ultimate goal is urine formation here. So we're going to talk about how we can get from here to here. Firstly, we need to start off with glomerular filtration. Let's write that as number 1. So, you know from previous videos that as the blood comes through, that there is a relatively high pressure here at the glomerulus. Now, remember that at most capillary beds, the pressure is around about 20 to 30 millimeters of mercury. So what's that mean? There's a hydrostatic pressure, a push behind the blood, pushing stuff out of the capillaries at the tissues of your body. But once you get here to the kidneys, this capillary bed is different and the push is greater. It's 50 millimeters of mercury, okay? So you have this very strong push, pushing substances within the blood plasma through, okay? Now remember, proteins do not go through and cells do not go through. Why? Well, cells are too big. So white blood cells, red blood cells and platelets, they're all too big to move through this filtration membrane, or I should say filtration membranes. Proteins, well, the proteins are actually small enough to get through, but there is a negative charge at this filtration membrane. And remember, proteins are negatively charged, and like charges repel each other. So in a healthy filtration membrane, proteins are repelled and stay in the blood. Okay, first thing. So filtration. Now, of the blood that comes down through into here, what you'll find is, so think about cardiac output, right? So your heart will contract and relax, contract and relax. And as it does this, it pushes out blood, right? So every time it contracts, it pushes out around about 70 mils of blood from one ventricle. So left ventricle, squirt, 70 mils of blood. And it does that about 72 times a minute. So if it squirts out 70 mils in one go, times 72 in a minute, that gives you around about 5 litres a minute. So your heart pushes out from one ventricle 5 litres a minute. That's the cardiac output. Now that 5 litres a minute goes to the whole body, right? So only a fraction of that's going to get to the kidneys. 20% of that will get to the kidneys. What's 20% of 5 litres? 1 litre. So 1 litre of blood goes to the kidneys every minute. Now that 1 litre of blood is made up of all these different components. It's made up of cells, it's made up of proteins, it's made up of blood plasma and so forth. What gets filtered? Only plasma, right? Because the cells and proteins don't go through. So of that 1 litre, what you'll find is 60% of it is plasma. So what's 60% of 1 litre? 600 mils. So you have 600 mils of blood plasma that's coming through that can be filtered. Now of this, how much of that 600 mils actually goes through? 20%. Okay, so 20% of this 600 mils gets filtered through. What's 20% of 600? It's 120 mils. So every minute in here, you have 120 mils being filtered through. So that means you create 120 mils of filtrate every minute in both your kidneys together. So not one nephron, this is representing of both your kidneys, okay? So 120 mils a minute is what your kidney creates of filtrate. Now think about that, 120 mils a minute. Now, let's do some very quick maths. How many minutes are there in an hour? 60 minutes in an hour. Okay, how many hours are there in a day? 24. So 60 times 24 is 1440 minutes. Okay, you have 1440 minutes in a day. Alright, and you have 120 mils per minute being made. So 120 times 1440, and this is something that I wrote down before, is 172,800 mils per day. Your kidneys create 172,800 mils of filtrate per day. That's approximately 175 litres a day. But you know that of this 175 litres, you don't pee out 175 litres a day. You actually pee out around about 1.7 litres per day. That's only 1%. So of everything that you filter through, you only pee out 1%. So let's just say here, 175 litres per day. Or by the time it gets to here, it's only 1.7 litres a day. So what does that mean? That means of everything you've filtered, 99% of it goes back into your blood, back into your body. Okay? So that means that in order to create urine, we need to add something else to this equation. We said urine formation is equal to glomerular filtration, which is 120 mils per minute, minus tubular reabsorption, right? So that's the tubules, and it's going back into the body, so it's reabsorption, not absorption, because you've already absorbed this stuff before in the GRT. You're reabsorbing it back into the body, okay? So this is step 2, tubular reabsorption. So let's just label this a bit better. Here, step 1, filtration, and this is step 2, tubular reabsorption. So, tubular reabsorption. You've got all these tubes. You've got the proximal convoluted tubule, you've got the loop of Henle, you've got the distal convoluted tubule, you've got the collecting duct. In actual fact, it happens all throughout. Okay? So if you were to have a look here, you'd find that at the proximal convoluted tubule, 65% of what's just been filtered goes back into the body at the proximal convoluted tubule. 65%. Okay? At the loop of Henle, what you'll find is that 15% goes back into the body. Okay? So what's that so far? 70, 80, 80%. Okay? Here, at the distal convoluted tubule, you'll find that another 15% gets reabsorbed back into the body. That's 95%. And here, at the collecting ducts, 4 to 5%. That equals 99% to 100%. Okay? Because remember, 99% of what just got filtered goes back into the body. 65% of it happens here at the proximal convoluted tubule, 15% happens at the loop of Henle, 15% happens at the distal convoluted tubule, and 4 to 5% happen at the collecting ducts. Now, the great thing is your body can alter this, so it's not always going to be 65%, 15, 15, and 4 to 5%. If you want to reabsorb more, this percentage can go up. If you want to reabsorb less, it can go down, and vice versa with all these. Okay, so for example, if you want to reabsorb more water, you can release ADH, antidiuretic hormone, which makes you reabsorb more water here at the collecting ducts. If you want to reabsorb more sodium into your body, you can release aldosterone, and this can tell the distal convoluted tubules to reabsorb more sodium. Okay, so urine formation is equal to glomerular filtration minus tubular reabsorption. So let me just wipe this off so I've got more room. So does that make sense why it's minus? Because remember, 120 mils per minute here, but we need to minus what's going back. 99%, so now we have 1.2 mils coming through, right? 120 mils, take 1% of that is 1.2 mils, because that 99%'s gone back. So now we only have, by the time we reach here, we only have 1.2 mils per minute, which is 1.7 litres a day, okay? Coming through at 1.2 litres a day. Now, that's not the end of it, because your nephron can actually take some stuff from the blood and not just give substances to the blood, it can receive substances from the blood. And this is number 3, and this is called tubular secretion. Now, why is it called secretion? Is because it's secreting substances from the blood into the tubule. People get confused about reabsorption, secretion, and so forth. Whatever is in the tube, you need to remember as essentially being outside the body. This is what's going to be peed out if it stays in the tube. So if it goes from the blood into this tubule, it's secretion. And this is number 3, tubular secretion. And again, this can happen at different stages or different parts of the nephron. Okay? But usually it's not a huge amount, okay? Not a huge amount. So what can we see? We can see when it comes to urine formation, it's made up of 3 different components. Glomerular filtration, which is about 120 mils a minute. Tubular reabsorption, throwing back 99% of all that stuff back into the body, okay? And tubular secretion, throwing out some stuff. This stuff is going to be, for example, urea. For example, this is urea can be thrown back into the tubules to be excreted or to be peed out. So this is urine formation. Hi everybody, Dr. Mike here. In this video, we're going to take a look at urinalysis. Now, urinalysis is a cheap, fast, and cost-effective diagnostic tool to have a look at what should or should not be present in the urine and can be a great indicator for disease or disorder. So let's go through what we can check in a urinalysis one by one. So first thing is, let's have a look at colour. So colour is something you can obviously just take and look at. It can be something that's clear, or it can be cloudy, or anything in between. It could be colourless, or it could be amber, for example, and anything in between. Now, what can change the colour of our urine can be anything from food to drugs, for example. It could be the presence of blood. What about from clear to cloudy? It could be the presence of proteins or anything dissolved in the urine, or maybe an indication of an infection. So just by looking at the urine can give you a great indication as to what may be going on. Specific gravity, this is the first test that we can actually perform using the urinalysis, or the dipstick, for example. And specific gravity is simply looking at the concentration of the urine. It's looking at the stuff in the urine. Now, specifically, what it's looking at is something called the osmolality. And the osmolality is that concentration of stuff in the urine. So for example, if I were to check the specific gravity of water, it's going to be 1, because there's nothing in water, it's just water itself. So it's the reference point, specific gravity of 1. Anytime you put anything into that water, so let's say we start to dissolve some ions, or maybe some proteins, or maybe some sugar or glucose, for example, it's going to increase the concentration of stuff in there, or the osmolality. Now this is going to increase the specific gravity. So if we take urine, it's obviously not going to be void of particulates or particles dissolved in it like water is. So it's going to be a value greater than 1. What you're going to find is for urine, the specific gravity is usually between 1.003 and 1.03. So what this indicates is that, for example, if something's above 1.03, it may be an indication of dehydration. So more stuff dissolved in the urine itself, or not enough fluid, and so the relative proportion of stuff dissolved in is greater compared to the fluid. If it's below 1.003, it's going to be an indication of hydration, maybe an indication of overhydration. What can specific gravity tell us? Well, again, apart from the relative hydration status, it can be an indication of the presence of other things. So for example, if it's above 1.03, so looking as though dehydrated, could be the presence of glucose in the urine. So glucose or glucosuria, which is an indication potentially of diabetes, for example. It could be an indication of something called syndrome of inappropriate antidiuretic hormone. What does that mean? So antidiuretic hormone, antidiuresis, to stop urinating. So ADH, antidiuretic hormone, pulls water back into the body. So syndrome of inappropriate antidiuretic hormone means it's pulling too much water back into the body, so the urine you produce is concentrated. So they could be just two potential reasons. Glucosuria or syndrome of inappropriate ADH can be an indication if the specific gravity is too high. If it's too low, for example, it could be an indication of something called diabetes insipidus. Now, diabetes mellitus, mellitus means sweet, sweet like sugar, because there's glucose or sugar in the urine. Diabetes insipidus, it's not sweet. There's no glucose in that urine. It's actually a problem up in the brain with not enough antidiuretic hormone being produced. So too much dilute urine is being produced, and that could be an indication of a low specific gravity. Again, they're all just indicators. So pH. pH is looking at the concentration of hydrogen ions, and obviously looking at pH can be a great way of looking at whether there's any acid-base imbalances. So for example, somebody can have a respiratory or metabolic acidosis or alkalosis. So that means too much or too little hydrogen ions. Respiratory based means it has to have something to do with the breathing. So maybe if you're retaining too much carbon dioxide, that turns to hydrogen ions and your blood becomes too acidic. Maybe you're breathing off or hyperventilating and you're getting rid of too much carbon dioxide. That could be an indication of alkalosis. Okay, so your pH starts to go up. Acidosis, pH goes down. Alkalosis, pH goes up. Metabolic means there's something going on in the body, usually at the kidneys, and it's retaining too much hydrogen ions or getting rid of too much bicarbonate, for example. This can bear out in the pH test of the urinalysis. But what you should know is what the normal pH is. So for example, the pH can vary from 4.5 to 8. So that's quite significant. Usually it's sitting for urine between 5.5 and 6.5. Now what's that telling you? It's telling you it's slightly acidic. Now you can change the acid base through food, for example. So ingesting proteins. Proteins are made up of amino acids, right? The acid portion gives you an indication. When we break down proteins and amino acids, we turn it into ammonia. Our body doesn't like handling ammonia, so it turns it into urea. That comes out in our urine, and urea is acidic. So if you have more proteins in your diet, your urine will be more acidic. Now, if the urine is more basic, it could be an indication that there's bacteria present that eat up or split the urea. So a UTI could be an indication of an alkaline-based or a basic urine because it's breaking up that urea. But it could also be an indication of a number of other things, like I said, food, for example. So pH, again, just an indicator. Glucose. All right, so glucose is small enough for our kidneys to filter. Remember, there's a filtration membrane called the glomerulus. So if I were to draw up the filtration unit of the kidney, called the nephron, there's different aspects of it. So right here is where you actually filter the blood. So the blood's going to come in, turn into something called a glomerulus, and then the blood's going to go out. And if it's small enough, it gets filtered through this sieve or this filtration membrane called the glomerular filtration membrane. Glucose is small enough to get filtered into this nephron and these tubules. But what should normally happen is all the glucose that gets filtered should be thrown back into the blood of the body. So what that means is anything that ends up at the other end of this tube, that comes out in our urine. So that means all the glucose that gets filtered actually gets thrown back into the body and doesn't come out in our urine. So our urine shouldn't actually have glucose in it. But if it does have glucose in it, what can it be an indication of? So maybe somebody has ingested far too much sugar, far too much glucose, and the transport molecules that bring it back into the body have been overwhelmed and it can't bring it all back. So there's an overload of glucose and it just carries out into the urine. Or it could be an indication of diabetes. So remember, diabetes is a problem with handling glucose. So type 1 diabetes, you don't produce the insulin. Type 2, you produce it, it just doesn't really work. And insulin is that key to tell the cells of the body, like muscle cells, for example, and fat cells, to take the glucose and bring it in from the blood. But if that insulin isn't there or doesn't work, the glucose stays in the blood and it overwhelms this filtration and it comes out in the urine. And as we know with diabetics, wherever the glucose goes, it pulls water with it. That's osmotic. That's an osmotic effect. And it can lead to increase in urine production as well. Polyuria, more urine being produced over time. So glucose, good indicator of diabetes. Ketones, also a good indicator of diabetes, but more specifically, type 1 diabetes. Now, why? What is ketones? So ketones usually aren't present in the urine. Ketones are an alternate energy source, alternate from glucose. That's our primary energy source. Ketones are an alternate energy source. What happens is this. Glucose turns into energy through a process known as glycolysis. Glucose goes to pyruvate. Pyruvate jumps into the Krebs cycle of the mitochondria. That creates products that jump into the electron transport chain that produces about 36 odd ATP molecules. Glucose can only do this if insulin's present. If insulin's not present, the body tries to make glucose. It makes it from non-glucose based sources like fats and proteins. And what happens is all these fats come in, get broken down, and they start to back up. And when they back up, they go through an alternate pathway of energy source production, and that's the pathway of ketones. Now, so type 1 diabetics, they produce zero insulin, right? No insulin. That means no glucose being utilized for energy. So all these ketones being produced. Type 2 diabetics, they do produce the insulin, which means the glucose is undergoing, whatever glucose gets into the cells is undergoing this glycolytic process. So the ketone production will be minimal. Right? So that's why type 1 diabetes producing ketones is a good indicator. But ketones are also produced when somebody is on a very low carbohydrate diet. So somebody could be producing ketones if they're not ingesting much glucose at all in the first place. So the only option is to produce the ketones for energy. Take the fatty acids, break it down to produce ketones. All right. Blood. Now, blood is probably not the right term to use here, but what we're referring to in this test is actually, it measures something called peroxidase activity. And peroxidase activity is actually an indicator of hemoglobin, myoglobin, and erythrocyte function. So hemoglobin, myoglobin, and erythrocyte function, that's actually what this aspect of the test picks up, not just blood. Now, hemoglobin carries oxygen around the body. Myoglobin carries oxygen in the muscle. That's what the myo is referring to. Erythrocyte is the red blood cell, which obviously carries hemoglobin. Now, generally speaking, erythrocytes do not get filtered. They're too big. Cells don't get filtered here at the glomerulus. So if you've got erythrocytes present, could be an indication that there's damage at this membrane, or there's some sort of infection or some sort of damage to the tubules itself or something lower down. Lower down could be the ureters, it could be the bladder, it could be the urethra, for example. What about myoglobin and hemoglobin? Well, they could be present. They do get filtered, right? But usually they get reabsorbed back in. So their presence in the urine is very low. So again, it's an overabundance that's going to lead to their presence in the urine, overproduction. So, for example, it could be somebody doing exercise. So marathon runners or somebody performing intense exercise may find that their hemoglobin, myoglobin levels in their urine goes up, but it should be transient. So it should obviously fix itself within 48, 72 hours. Or it could be a crush injury. So if something crushes the muscle, it's going to release all this myoglobin. And again, that's going to come out in the urine. So it could be an indicator of that. But again, could also be an indicator that there's damage to the filtration membrane itself, or the nephrons, or the tubules, for example, or something lower down. So an infection could actually increase those numbers. Protein. So the only types of proteins that can get filtered are proteins that are less than 20,000 Daltons in size. That's the molecular weight. So anything that's smaller than that gets filtered at the glomerulus. Some proteins are greater than that, some proteins are smaller. Some proteins that are smaller than that get filtered include albumin and some globulins. They're usually carrier molecules. So sometimes they're going to be carrying insoluble substances and they get filtered through. Again, a lot of it gets reabsorbed back into the body. Some of it does come out. So what can increase the presence of protein? Well, it can happen transiently or long term. So transiently, things like heart failure can do it, increasing that pressure that's happening. It could be damage to the glomerulus, so glomerulonephritis can cause this as well. So that's usually a long-term cause. So it could be short-term or long-term. Short-term, heart failure, exercise, fever, stress. Long-term, usually some sort of nephropathy, such as glomerulonephritis, can increase the presence of proteins. Nitrites. All right. You usually should have 0 nitrites in your urine. You shouldn't have any at all. You have nitrates, but no nitrites. But what happens is we can have the presence of bacteria, and these bacteria can turn the nitrates, with the A, into nitrites, with the I. And so the presence of nitrites tell you there is bacteria present, which can be an indication of a urinary tract infection, wherever that infection may be. Leukocytes, white blood cells, good indication of infection. So this infection, again, could be a great indicator of UTI, but usually you'd need to do some sort of culture to say that bacteria is present for a UTI. If not, no bacteria present, could be just some type of itis, right? Some sort of inflammatory response that's happening. So it could be inflammation of the nephron itself, of the kidney, something of the ureter, bladder, urethra. So this could also increase the amount of leukocytes present. All right, last one, bilirubin and urobilinogen. Your red blood cells, when they die, they go to the spleen. So you've got red blood cells, they go to the spleen. The spleen breaks up hemoglobin and globin, and the heme goes to the liver, and the liver turns it into bilirubin. All right, that's the first thing, bilirubin. Now, bilirubin can be unconjugated or conjugated. The liver conjugates it. What that means is it makes it water soluble so it can float around in the water of our body. If it's water soluble, it can be filtered. So some conjugated bilirubin can be present in the urine, some. What usually happens is this, the liver that makes the bilirubin conjugates it and sends it to the bile, right? Which is the gallbladder. And the gallbladder releases it into the small intestines. And so this can come out in our fecal material, or it can get reabsorbed back to the liver. All right, now here's the thing. When it's in the bile, as in the small intestines, this is where it turns into urobilinogen. Bilinogen. Okay? And again, this can go to the liver for reabsorption. So, what is all this telling you? This is all telling you that the presence of bilirubin and urobilinogen in the urine can be an indication that too many red blood cells are breaking down. This is known as hemolysis. It could be an indicator that the liver is dysfunctional. All right, so some sort of hepatic disease, or maybe some sort of hepatocellular disease. Or it can be an indication that there's a problem with the bile or bile ducts, so the biliary system. That's what it's telling you. That's what it's an indicator of. So this is a quick run through of urinalysis. Hi everybody, Dr. Mike here. In this video, we're going to take a look at body fluids and electrolytes. So the first thing is, if you take a 70 kilogram male such as myself and have a look at the composition of body fluid, 65% of me will be water. Now this is going to change depending on an individual's body composition. More fat, less water. Less fat, more water. The older you are, less water. The younger you are, more water. So all these need to be taken into consideration when thinking about fluid balance for individuals. Now within this fluid we have things that are dissolved. So for example we have ions. Now ions are when you take an electrolyte, which is basically a salt. So sodium chloride. And when you put sodium chloride, for example, which is just salt, right? Table salt, for example. You ingest it. Once it hits the fluids of your body, it splits off and forms a positive sodium and a negative chloride. Together, they balance each other's charge out. Now they're called ions. That's an electrolyte. These are now ions. So if we look at the ion distribution within our body, because they influence the movement of water and therefore influence where the water sits within the compartments of our body. Now, the compartments of our body can be broken up into two particular compartments. That is inside the cell, that's one compartment. The fluid that sits inside the cell is called intracellular fluid, or ICF. So I can put in here, this is intracellular fluid, or it can be the fluid that sits outside the cell that we term extracellular fluid. So that's going to be out here, but also within the blood vessels. So all the fluid within the blood vessels is recognized as being extracellular fluid. Now they're two separate compartments, obviously. So you've got intracellular fluid, everything inside the cell, extracellular fluid, or the fluid outside the cell, and the extracellular fluid compartment is broken up into two subcompartments. What are these compartments? It is the area that sits outside the cell and between the cells. That is called the interstitium. So interstitial fluid, and the other one is inside the blood vessels, and we call this intravascular. Now the intravascular fluid is basically blood plasma. So this is how we break up body fluids within different compartments of the body. Now let's talk about ions and where they sit. So firstly, outside the cell, you have large amounts of sodium, chloride, calcium, and bicarbonate. You can see you've got some are positive like sodium and calcium, some are negative like chloride and bicarbonate. Inside the cell, what you have is potassium, you're going to have phosphate, you're going to have magnesium, and you're going to have negatively charged proteins. Again, some of these are going to be positive like potassium and magnesium. Some of these are going to be negative like phosphate and proteins. Now, as you can see, you have different ions sitting in different compartments. Now, there are going to be some potassium outside and phosphate and magnesium and some proteins outside, and there's going to be some sodium, chloride, calcium, bicarbonate inside, but predominantly the most abundant positive ion that sits outside the cell is sodium. The most abundant positive ion that sits inside the cell is potassium, all right? And you can see the others break up like this. Now, the other important point is all the ions that sit outside the cell in the interstitium, the extracellular fluid, because extracellular fluid is both the interstitium and intravascular, that means everything here is exchangeable with everything here. So things can go back and forth. They are exchangeable. And so whatever ions are outside are inside. So that means sodium, chloride, calcium, and bicarbonate are in the same concentrations inside your bloodstream as they are floating around outside your cells. So that means if you get something injected into your bloodstream, it will then jump out of the bloodstream and float around outside your cells. So if you get a saline bag, which is just sodium and chloride, injected in high concentrations, that's going to increase in the blood vessel, that's going to move out and increase outside the cell, and that's going to influence movement of water. Now, the question is, why does it influence movement of water? Because the concentrations here, first of all, are balanced. Now you may think, well, no, they're not. There's more sodium outside and more potassium inside, more chloride outside, more phosphate inside. Yes, but if you add up the concentration of these things inside the cell and compare them to the concentration of things outside the cell, it's the same concentration. And we measure the concentration in something called milliosmoles. And the concentration is around about 290 milliosmoles. That means when I add up all the stuff dissolved outside the cell, it's 290 milliosmoles. When I add up all the stuff inside the cell, it's 290 milliosmoles. That is perfect. How do we calculate this? Well, we calculate it like this, right? You find out how much sodium you have and multiply it by 2. You find out how much potassium you have, you multiply it by 2. You add how much glucose we have and add it to how much urea we have, and then what you get is 290 milliosmoles. How do we know? Well, 2 times 135 millimoles per litre, which is around about the amount of sodium we have, plus 2 times potassium, which is around about 5 millimoles per litre, plus 5 millimoles per litre of glucose, plus 5 millimoles per litre of urea. What's that going to give us? 2 times 135 is 170, plus 10, plus 5, plus 5. What's that? 10 plus 10 equals 20, plus 170 is, 270 is 290. So we've got 290 milliosmoles. That also means if you increase the amount of sodium or glucose, urea or potassium, it's going to change that concentration. Now here's the other thing. Let's just say you do intravenously put in huge amounts of sodium. You increase the amount of sodium inside the blood vessel. So now we've got all this sodium. What's going to happen? Well, because whatever's in the blood vessel is exchangeable with what's outside, all this sodium moves outside. Now we've got huge amounts of sodium sitting outside the blood vessel. That means you increase the amount of sodium here. What happens to the concentration? It goes up. It's now no longer 290 milliosmoles outside. It's 310, for example. What's inside? Inside is still 290 milliosmoles. The concentration has changed, and the body hates it when there's a concentration difference from outside the cell compared to inside the cell. Water will move. Why won't these ions move? Because that's a fatty layer of the cell, and the cell membrane or the fatty layer does not let anything through that is large or charged. Doesn't let it through. So these ions stay in their compartments, but the water must shift. So if it's more concentrated outside than inside, where does the water move to dilute out that high concentration? Water's going to move from inside outside. And what that means is this gets diluted, so that starts to drop back down, but this increases and goes up. So that'll probably go to 300 now, and this will go up to 300. Now it's balanced, which is great, but you still have too much ions in the body. And this is where your kidneys come into play and pee it out, okay? So this is a really, really important point when it comes to fluid balance and electrolytes. Sometimes you can lose these ions through sweat or exercise, and that means this concentration drops. If this concentration drops, something's going to happen. What's that thing that happens? Is you need to ingest more salt. You feel like eating salty foods. What if only your fluid drops, right? What if you've got a container filled with stuff and you sweat out more liquid than you do ions, right? So this volume of water drops down to here, but the amount of ions stay relatively the same. This is called dehydration. The concentration goes up. When the concentration goes up, this same thing happens, but it also goes to the hypothalamus, and the hypothalamus tells you you're thirsty and you drink some water. So this is a quick overview of body fluids and electrolytes. Hi everybody, Dr. Mike here. In this video, we're going to talk about dehydration. Now, dehydration is defined by a loss of total body fluid. Now, not all dehydration is the same. Today, I'm going to talk about 2 different types of dehydration, one that we call intracellular dehydration and one that we call extracellular dehydration. First thing you need to be aware of, which I've spoken about in previous videos, is that if we have a cell and have a look at all the stuff inside the cell, so this may be ions like sodium or potassium or magnesium or chloride or whatever it may be, and look at its concentration inside the cell, compare it to the concentration of all that stuff outside the cell, what you're going to find is that the concentration normally is the same. This concentration is 290 milliosmoles outside the cell, 290 milliosmoles inside the cell. That's the same. Now what that basically means is that water will be moving in that direction and that direction at around about the same rate, which means there's no net shifting of fluid between the intracellular compartments and extracellular compartments. Now remember, 2/3 of your water is inside the cell, 1/3 of your water is sitting outside the cell, okay? When the concentration of stuff is the same inside compared to outside, there's no overall net movement of fluid one way or the other. However, let's talk about intracellular dehydration. Let's just say that you do some exercise. Now, when you exercise, you obviously sweat. And the reason why you sweat is because that fluid or water that's coming out of your skin is going to transfer heat away. When a breeze goes past, it takes heat away. In actual fact, about 580 kilocalories of heat will be taken away per kilogram of sweat. How much do you sweat during exercise? Anywhere between 0.5 to 2 liters per hour, depending on how intense you're exercising. So exercise and sweat glands are a way to release this fluid. These sweat glands predominantly are eccrine sweat glands. And if you think about what is inside of it, predominantly it's water, right? But there's also going to be some salts like sodium and chloride and magnesium and potassium and so forth. Now remember this, in the base of these eccrine glands, right? So you got the base of the gland and then it snakes its way up to the skin. Here, where it's forming the sweat, it's going to contain water and the sodium and potassium and chloride and magnesium and so forth, right? Those ions. Now, the concentration of those things inside the sweat gland when it's being made is the same as the concentration inside the cells. Okay. When it starts to move its way up through the gland, those substances start to get actively reabsorbed back into the body. And by the time you sweat and the sweat goes onto your skin, the concentration of those substances inside your sweat is less than the concentration of those substances inside your cell. We call that a hypotonic solution. Now, when it's the same concentration, that's called an isotonic solution. You've probably heard of that before with a Gatorade. All it's saying is that in that Gatorade, that water, you have a whole bunch of salts in there that's at the same concentration as your blood or your cells, okay? Hypo means it's less concentrated than your blood or your cells. Hyper means it's more concentrated than your blood or your cells. Got it? Now, that means you do exercise, you start to sweat, like I said, 0.5 or 2 liters per hour of this sweat, which contains some salt, but what you find is most of that salt gets thrown back into your body. You end up sweating or releasing more water than you do all the substances dissolved in your water. So basically, what's happening is this. You have a container, and this container has water in it, and some stuff dissolved in it. When you do exercise, you lose a whole bunch of water and only a few of these things, but significant amounts of water have been lost. Now think about what that means. If most of, and this is happening from all the fluid outside the cells, right? So I'm pulling out some of this water and keeping most of these dissolved substances. That means this fluid outside the cell becomes more concentrated. All right? And if it becomes more concentrated, this may jump up to 310 milliosmoles, for example. Now, if it does, what that now means is there's a concentration difference from outside the cell to inside the cell, and your body hates it. The only way your body can fix this is by shifting fluids between inside the cell to outside the cell. Now, water will try and balance this out, and it does it by moving in one direction, from inside the cell to outside the cell. And so it slowly drops that to 300 milliosmoles, and this concentration inside rises to around about 300 milliosmoles. But think about what's happened. Through exercise and sweating, water has been taken out of our cells, and those cells begin to shrink. When these cells shrink, that means you get intracellular dehydration. Intracellular dehydration. That's what it's called. Now, when these cells start to dehydrate in the brain, they specifically will do this to all the cells, but they specifically will do it to cells in the hypothalamus. Hypothalamus picks up this change in concentration, sends a signal down to the posterior portion of the hypothalamus, the posterior portion of the pituitary gland, and tell it to release something called antidiuretic hormone, ADH. ADH, as a hormone, travels through the bloodstream, goes down to the kidneys, specifically goes to the nephrons. I've spoken to you about the nephrons. Watch one of those videos if you don't know about them. What ADH does is it puts little holes in these tubules to tell the water that was going to turn into pee to be thrown back into the blood. ADH increases water reabsorption. And when that happens, we replenish the volume of water outside, pushes that water back inside. All right? So this is what happens in intracellular dehydration. At the same time, the hypothalamus will send signals to the cortex of your brain and tell you that you're thirsty and drink. That means the response to intracellular dehydration will be a hormonal response, ADH, and a behavioral response to drink. Now let's compare this to extracellular dehydration. What's happening here is something different. This is where your water loss outside your cells, so again, remember, you're going to have a concentration of stuff outside the cell and inside the cell, 290 milliosmoles, and now what happens in extracellular dehydration is the fluid outside the cells is being lost at the same concentration as what it is outside the cell here. So you're not just losing water like we were with intracellular dehydration, mostly water, you're losing water and the dissolved substances at the same concentration that they are here, which means the whole fluid level drops, but it still remains 290 milliosmoles. Think about it like this. I've got that container with some particles in it. Let's say I've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 particles and 1 litre. 10 particles per litre, right? Per 1 litre. Let's now say I lose water and particles at the same rate. So I go down to 5 particles per half a litre. 5 particles per half a litre is exactly the same as 10 particles per 1 litre. It's still 290 milliosmoles, which means there's no concentration difference from inside the cell to outside the cell. Is there going to be water moving out? No. So the cells remain hydrated, but outside the cells, we've lost our fluid volume. I told you in a previous video that the extracellular fluid is the same as the blood fluid, which means your blood volume drops. If your blood volume drops, your blood pressure drops. If your blood pressure drops, your tissues don't get the oxygen and nutrients it needs, specifically here at the kidneys, at the nephrons. We need to filter, remember, 120 mils per minute of blood. If your blood pressure and volume drops, that drops. You don't filter your blood properly. Your kidneys, they're not happy with this. So they release a hormone called renin, specifically from here. At the afferent arteriole, renin is released. Renin does a whole bunch of things. Renin does a whole bunch of things to increase blood pressure. I've done a video on renin, watch that. Increases the blood pressure. It does it by going to the brain, specifically the hypothalamus, and releasing ADH. It also tells all the blood vessels to constrict. If you constrict a hose, the water backs up and the pressure increases. Perfect, that's what we want as well. It releases something called aldosterone. Aldosterone comes from the kidneys. You got the cap on the kidneys called the adrenal gland. Aldosterone is produced there. Is released, goes to the distal convoluted tubule and the collecting ducts to reabsorb salt back into the body. If salt is pulled back into the body, water's pulled back into the body. If water's pulled back into the body, blood volume goes back up, blood pressure goes back up, and everything is sorted. The renin-angiotensin aldosterone system is a system that gets activated when our blood volume drops and our blood pressure drops. And the whole purpose of it is to increase blood volume, increase blood pressure. So let's have a look and see how this system works. If you have a look, renin-angiotensin aldosterone, 3 different terms, and they're released in that particular order. So the first thing we need to talk about itself is renin. Now, if you were to take the kidneys, you should know that the filtration system is called the nephron, and there's about 1 million nephrons per kidney. Now, the majority of the nephrons sits in the cortex of the kidney, but the loop of Henle and the collecting ducts sit within the renal pyramids, also known as the medullary pyramids. If we were to take a single nephron out and we were to stick it here, what you'll find is that there's an afferent arteriole, which is blood coming in, and then it turns into a capillary network called the glomerulus, then an efferent arteriole coming out. Now, what you need to be aware of is that your kidneys need to filter about 120 milliliters of blood per minute, or they need to create 120 milliliters of filtrate per minute. That means when this blood comes in, of this blood, it needs to get filtered into this glomerular capsule, and 120 milliliters of what's now called filtrate is produced per minute. That means about 180 liters per day of filtrate is produced. However, of that 180 liters that we produce per day, we don't pee out all of that 180 liters, as I'm sure you're aware. We pee out only 1% of that, 1.8 liters. So that means 99% of what we filter at the glomerulus is thrown back into the body, back into the bloodstream. Now, this is important because the kidneys are basically weighing up exactly what we need, what we don't need. Okay, now this is why the kidneys must maintain this consistent, what's called glomerular filtration rate of 120 mils per minute. If your blood volume drops, for example, due to a bleed out, so hemorrhage, or due to some sort of peripheral vasodilation, which may happen due to anaphylactic shock, for example, your blood pressure drops and your blood volume drops. Now that means that the kidneys at the glomerulus will not be able to filter that 120 milliliters per minute. And this is a stimulus to release the first component of the renin-angiotensin-aldosterone system called renin. Now where is renin specifically released from? Well, let's have a look. In the afferent arteriole, the blood coming in, there are some cells in the walls of the afferent arteriole. Now these cells are called juxtaglomerular cells, also known as renin-releasing granular cells. So they're called juxtaglomerular cells, also known as granular cells. Granular cells. Now, these are the cells that actually release renin. Now, renin is an enzyme, okay? It's not a hormone, it's an enzyme, and it's released by the granular cells of the afferent arteriole. Okay, now what stimulates its release? I told you a drop in blood volume, drop in blood pressure, but how does it know this? Well, it knows this because as the blood that's coming in, if the blood volume has dropped and therefore blood pressure has dropped, these juxtaglomerular cells or granular cells are actually baroreceptors. And they pick up that drop in blood pressure. And then they release renin. So the first way renin is released, is a drop in blood pressure in afferent arteriole. That's the first way. Now there's another way that renin can be released. Now think about this. If the blood pressure has dropped and the blood volume has dropped, that means the blood's moving through quite slowly with less of a force or push behind it. So it comes through to the glomerulus, gets filtered, and now you've created filtrate here. Now think about it. If the blood pressure is low, blood volume is low, this filtrate's going to move through slowly. Now if it moves through slowly, remember that at the proximal convoluted tubule, this is where we reabsorb approximately 65% of all the stuff that gets thrown back into the body. That includes sodium. And then at the loop of Henle, around about 15% is thrown back at the loop of Henle. And the other portion, so the descending and ascending portions of the loop of Henle, and then about 5% is thrown back at the distal convoluted tubule. This is of sodium, okay? Now, if this filtrate is moving through slowly, think about it, there's more time for this salt to be pulled back into the body, which means more sodium gets taken out of the tubules and thrown back into the body, which means by the time we reach the distal convoluted tubule, is there going to be less sodium or more sodium? There's going to be less sodium. This is the next trigger to release renin. But how? If we're in the distal convoluted tubule and these cells are here, well, there's a cell type in the distal convoluted tubule that measure concentration. They're called macular denser cells. Macular denser cells. They measure concentration, so they're chemoreceptors. And what they do is there's actually, you can see that the afferent arteriole comes into close proximity with the distal convoluted tubule. They're very close together. In actual fact, they're connected by connective tissue. And this allows for a conversation to be had from the distal convoluted tubule to the afferent arteriole, specifically the macular denser cells to the granular cells. And therefore, when these macular denser cells pick up a drop in sodium in the distal convoluted tubule, they tell the granular cells to release renin. So what's the second reason why we release renin? Is a drop in sodium concentration in the distal convoluted tubule. Okay? Now there's a third thing that stimulates the release of renin, and it is direct innervation from the sympathetic nervous system. That's the fight or flight system. Think about that. In times of fight or flight, we want to increase our blood pressure. We want to increase our blood pressure. Why? Because it means our heart can deliver more blood to the muscles so it can fight or run away. And so this is the third reason, or the third way in which renin is released: increased sympathetic nervous system innervation. All right, so the first thing you need to know is what triggers the release of renin? Three things. One, a drop in blood pressure, which triggers the granular cells to directly release renin in the afferent arteriole. Two, a drop in sodium concentration in the distal convoluted tubule. This is picked up by the macular denser cells, which then speak to the granular cells to release renin. And three, the sympathetic nervous system directly innervates the granular cells to release renin. So now we've spoken about how renin is released in the first instance. We now need to talk about how the rest are released and how it actually increases blood volume, increases blood pressure. Well, let's move over to this part of the diagram now. Now, what I've just said to you is that renin has been released from the kidneys. Now, renin is released from the kidneys into the systemic circulation. It's floating around. Now, the liver produces and also stores many proteins as well. And usually, if it's something that's stored and inactive, it has the suffix OGEN on the end of it. And what the liver produces and stores is something called angiotensinogen. Again, another protein, angiotensinogen. Angio is referring to blood vessels. Tensin refers to pressure. OGEN tells you it's stored and inactive. And what's going to happen? Angiotensinogen is released into the bloodstream and comes across renin, which I said is an enzyme. What does this enzyme do? Well, renin chops off that OGEN and creates something called angiotensin 1. I'm just going to write AT1. Angiotensin 1. What does angiotensin 1 do? Not too much. It is a very slight vasoconstrictor, but clinically doesn't really matter. Angiotensin 1 now is floating around. Now the thing is that angiotensin 1, as it floats around the bloodstream, is inevitably going to get to the lungs. Now the lung produces the most amount of an enzyme called angiotensin converting enzyme. Let's write that down. I'll write it down up here. Angiotensin converting enzyme, ACE. So it produces something called ACE. Now, think about what it does. Angiotensin converting enzyme, it's going to convert angiotensin 1 into something called angiotensin 2. Now, this is what we're interested in, angiotensin 2. Angiotensin 2 is what we're interested in. What does it do? Couple of things. First thing is that angiotensin 2 is a generalized vasoconstrictor. It's predominantly going to constrict arterioles, which means the blood's going to back up, back up, back up, and increase blood pressure. So when you have a generalized vasoconstrictor, what is the ultimate outcome for a generalized vasoconstrictor? It ends up increasing blood pressure. What's the second thing that angiotensin 2 does? Well, angiotensin 2 also goes to the efferent arteriole. And when it gets to the efferent arteriole, remember, arterioles, when you hear the word arteriole, it's a small artery. They have huge amounts of smooth muscle. And so what angiotensin 2 does is it goes to this smooth muscle that's wrapped around the efferent arteriole and it tells it to constrict. What does that mean? If these arterioles are constricting, blood is backing up into the glomerulus. That increases filtration rate, which is exactly what we wanted because the stimulus was a decreased filtration rate, right? When that decreased filtration rate happened, we had all the sodium get thrown back into the body and the sodium levels were low. That was the trigger. Now we've got negative feedback. We've fixed it up. There's going to be no more trigger there. So the second thing that angiotensin 2 does is it constricts the efferent arteriole. And what's the outcome for constricting the efferent arteriole? Increasing glomerular filtration rate, which also increases the sodium in the distal convoluted tubule. Okay, what else does angiotensin 2 do? Angiotensin 2 will also travel, importantly, all the way to the adrenal gland. Specifically, it's going to travel to the cortex of the adrenal gland and stimulate it to release something called aldosterone, the last part of the renin-angiotensin aldosterone system. Aldosterone. Now, what does aldosterone do? Aldosterone travels to the distal convoluted tubule and it tells the distal convoluted tubule to take the sodium that's present and throw it back into the body. Now, why would we want that? If our blood volume's low and our blood pressure is low, why would we want to throw more sodium back into the body? Well, remember, wherever sodium goes, water follows. Therefore, sodium back into the body, sodium back into the blood, water back into the blood, increase blood volume. That's the outcome. So number 3, aldosterone from adrenal cortex. And what's it do? Increases sodium reabsorption, which ends up increasing blood volume, which ends up increasing blood pressure. What's the last thing that I want you to know that angiotensin 2 does? Well, it travels to the hypothalamus. Now, the hypothalamus is the master regulator of the endocrine system, right? And what that means is that endocrine system, hypothalamus, 2 pituitary glands, anterior, posterior. The posterior pituitary gland has ADH, antidiuretic hormone, diuresis, to urinate, antidiuresis, to stop urinating. So angiotensin 2 tells ADH, antidiuretic hormone, to be released into the body, and this will travel to the distal convoluted tubule and the collecting ducts and tell them to reabsorb more water into the body. Reabsorb more water into the body. That's what ADH does. This happens at the distal convoluted tubule and collecting ducts. Why more water? Again, more blood volume, more blood pressure. So the last thing I want you to know that angiotensin 2 does, stimulates the release of antidiuretic hormone from the posterior pituitary gland. And this resulted in what? Resulted in increased water reabsorption, which increased blood volume, which increased blood pressure. There you go. What was the stimulus? Stimulus was drop in blood volume, drop in blood pressure. What was the outcome when you stimulate renin-angiotensin aldosterone system? Increase in blood volume, increase in blood pressure. Hope that makes sense.